Hello, I'm Jonathan Esquivel from the Louisiana State University School of Dentistry, Department of Prosthodontics, and I want to thank all of you for sharing a few minutes of your day to discuss with me an interesting topic, which is implants in the aesthetic sector. Now, we're going to approach this topic from a prosthodontic standpoint. That means we're going to take basic prosthodontic principles to hopefully deliver good-looking results and have somewhat of predictability. The first thing I like to ask myself when I talk about implants in the aesthetic sector is, what is the true definition of the word success in this type of cases? Is it just having implants in the bone that are not hurting, that are not moving, or have no radiolucencies? Or is it something a little bit more complex than that? The truth of the matter is that with time, implants have evolved. And with this evolution of implants, so has the word success, both for the patient as for the clinician. Now, patients demand a little bit more than they did 20, 30 years ago. And this happens just because patients nowadays have access to the internet. And by having access to the internet, they become much more educated of what they want and have a better perception of what aesthetics and what good-looking implant restorations should look like. Now, whenever we're going to do aesthetics in implants that involve the anterior sector, we got to have a good treatment plan approach. For these cases, I have used the digital smile design approach by Dr. Christian Cochin. I like this treatment planning approach because it allows me to show my patient things. It allows me to draw diagrams on pictures from the moment they come into my dental unit and I take a few pictures of them. I can start showing them what I'm thinking of. Whenever we do this type of cases and we have this type of patients which are very special, it is very important to do something special. It is very important to reverse engineer these cases. We're going to try to look at the end result, and then we're going to start to decipher what steps we have to follow to achieve this end result and make it look good. Very important as well is not only to have one plan, but to have contingency plans. That means if our plan A does not work, then we can have a plan B or a plan C. This way we can also always deliver good looking restorations in the patient and not be stuck within four walls that would lead us to a lot of problems. Very important. We gotta know what type of tooth we're gonna restore. By knowing the basic shapes of teeth, we're going to see, is this a case in which I'm just going to restore that absent tooth, or is this a case that I'm going to need to do multiple restorations in adjacent teeth to be able to mimic and make it look nice or make it look natural. First example, the case we have right here. This patient has a tapered ovoid shaped tooth. She's missing number 8 and number 7. If I were to do a duplicate of number 9 using the digital smile design concept, I can start seeing things. First thing I see is that embrasure between the two teeth is going to be very hard to fill with papilla. If we do some kind of modification to tooth number 9, then it will make this embrasure a little bit easier to fill and it will be a more predictable result. Now, what type of restorations we do, that goes to your prosthetic judgment, to your clinical judgment. Are we going to do a composite? Are we going to do a veneer? Are we just simply going to do an ameloplasty on this tooth? Very important when we see these cases is to understand that we have to do a three-dimensional study of them. That means we got to see where the teeth is going to go, mesiodistally, cervical occlusally or cervical incisally, and buccolingually, as well as the soft tissues and the bone. How much bulk of bone do we need? How much soft tissue do we need? How much do we have to bring this soft tissue down? Once we have all those answers, then we can start thinking of where we're going to place our implants, how we're going to restore these implants. But we need a starting point. Whenever we do these cases, we need to have a good place to start. And the incisal edge position, like we know, is a very important place to start our treatments when it involves aesthetic cases. Now, another thing we have to look into is the contours of the teeth. Where is the zenith point located in the natural tooth that the patient still has in the mouth? Where are we going to locate that zenith point? Because based on this, we're going to start planning at what depth we're going to place that implant, in what position we're going to place that dental implant. Once we have that information and we've decided at what depth we're going to place that implant and in what position, then we can start thinking, okay, I got to make soft tissues follow the contours that are going to make this peri-implant site look like a periodontal site, make it look like a tooth. And I don't want it just to look like a restoration on an implant. I want to make it look like it's a natural tooth emerging from the tissues. Now, we know there's basic rules we have to follow whenever we place implants in the aesthetic sector. We know that mesiodistally they should be 1.5 millimeters away from teeth, 3 millimeters away from another implant, and in chronic apical position we got to have them 3 to 4 millimeters away from the restorative zenith point. Now, all these things are very important to follow because they're going to lead us to have that very good looking restoration at the end. Why do I like the digital smile design? Let's see this case that presented to the clinic at LSU School of Dentistry. Patient presented missing 3 teeth in the anterior sector. We did a digital smile design in which we copied the ideal position of teeth in the anterior sector. At the moment we copied the ideal position of teeth, we started seeing things and we could explain to our patients. What is the first thing we could explain to this patient? For us to set that incisal edge position and in that central, lateral, canine, etc. in the adequate place, then we would have to do a series of surgeries, and we could not guarantee that we were going to have this soft tissue look good, or we have to bring that canine down to make it look a little bit more natural, that bicuspid down to make it look a little bit more natural, among other things. So the patient starts understanding that it would be very hard for us to fill all this soft tissue deficiency, and that we could not guarantee that we can give her a good looking result. Now this helps us because it kind of lowers the expectations of the patient and brings them back to reality. What do we do now? We know we cannot achieve this unless we start doing a series of treatments, and most likely we would end up using some pink composite or some ceramics around those restorations. But what we do at this point is that we modify our digital smile design, and based on these modifications that are going to take us to something a little bit more real, then we start mounting our cases based on pictures, based on our design, and from this digital mounting in which we have incorporated images into cast, into the articulator, then we can start doing our wax-ups. Very important at this point for implant dentistry. Why is this wax-up so important? By using this wax-up to develop a mock-up on our patients, we can have a direct impact on them, a direct impact psychologically and in treatment planning options. That means that I can use this mock-up to show them we're not going to have this papilla between the lateral and the central, or it's going to even be hard to develop this papilla between the two centrals. But most importantly, I can use this mock-up to get some imaging done. That means this mock-up can be used as a guide for me to plan my surgery and know where to position those implants, in a coronal position, in a buccolingual position, in a mesiodistal position, and be more predictable at the end of treatment. It can also help me change my treatment plans in case I want to avoid any kind of anatomic structures and take decisions at this time. Let's see the first case. Sometimes in our clinic we have patients coming in missing one single tooth, and we gotta think, do we have to make alterations to other teeth to make this restoration look good? In this case, we have some visual asymmetries between the gingival lines of other teeth, so we know that placing the implant is not going to be the only thing we need to do in this case. We need to plan, where are we going to leave the cervical margins of those crowns? What do we have to do on the opposing lateral? And once we have determined all this, then we're going to decide, okay, we're going to place this implant at this depth, in this buccolingual position, in this mesiodistal position, and take decisions if we need to graft soft tissues or if we need to graft some bone to give it a better bulk and make it look a little bit nicer. Okay? So once we have all this information, we can also send it to our surgeon, send it to our periodontist, and based on this, they can discuss with us if they believe that a soft tissue graft would do, or if they need to place a little bit of bone to bulk this out. Patient was sent to orthodontics to do some changes. Once those spaces were well distributed, the implant was placed. In this case, the spacing for the implant was very narrow, so a 3mm implant was delivered on this patient. When we have 3mm implants, there are some companies that could not mill zirconia abutments because the connections would be too thin. In this case, we had to use a titanium abutment, and we had to find a way to mask this titanium with a restoration. Now, if you have a good ceramist, then the ceramist can come along and do restorations that can be good looking and have predictable results. Sometimes we also have patients that come in that are going to lose multiple teeth. They're going to be extracted, or sometimes they don't even have these teeth in the mouth. And we have to take things into consideration. How can we maintain the soft tissues where they are? Do we want to maintain the soft tissues? Do we want to alter them at some point? Or do we want to modify them and do some kind of treatment that will help us retain these tissues at the position where they're at this point, or help them migrate a little bit apically or a little bit incisally so they look better? First thing we do is take all restorations off and see if we can use this abutments for other procedures like orthodontic extrusion, among others. Like I said, very important whenever we treat cases, whether it is one tooth or two teeth, first thing we have to establish is the incisal edge position. So everything we do has to be based on what? It's got to be based on our prosthetic wax-ups or whatever type of design you've made. If you've used a digital smile design and then passed it to a mock-up, then it can be based on our mock-ups as well. If we do this, then our surgeon is going to have a good idea of where implants are going to go, and the result at the end is going to be very good looking. It's going to be very predictable. Once we've delivered our wax up in the mouth and made our mock-ups and we make impressions out of it, if we like it, we can pretty much design our surgical guides from this and have surgeries that are prosthetically driven. This means our periodontist and our oral surgeon is going to use our prosthetic guides and the estimated position of our central incisors in this case to place those implants at the right depth and at the right position. If we do this, if we have good driven surgeries, we're going to have precision when we have restorations in the patient's mouth. So it's all about teamwork. It's all about a very good interdisciplinary approach. If we can achieve this, then we're going to have patients that are going to be very satisfied with our work, and of course us as clinicians are going to be very satisfied as well. Very important when we do this case is to decide whether we're going to immediately load this implant cases or whether we're going to just put these implants to rest for a period of time and have them also integrate before we go to second stage surgery and do uncovery. In the case like this, we decided to go to do second stage surgery and not load them at the first attempt because we had some bone deficiencies and we thought it'd be better if the patient had the implants just submerged for a period of 6 months and then we came back to them. Once we have the implants uncovered, we got to think, do we want to have healing abutments on these implants or do we want to have good looking provisionals that have fairly good emergence profiles that are going to help us mold these tissues? What we do is we deliver good looking provisionals that are going to help mold these tissues, let the tissue rest before we start making modifications for a couple of months until it's matured a little bit more. Once it's matured, I can start working with the contours of my provisionals until I achieve something that looks good and it's going to give me good information to send to my lab technician. Once I have this, if I have the contours that look good and the provisionals are adequate, my papilla is looking good, my soft tissue is looking good around all the aspects of the contours of this provisional crowns, then I can make impressions. But how do I do to make these impressions and send all this information to my lab technician? I want to replicate this emergence profile, so I'm going to do a custom-made impression copy. Using my provisional and making a duplicate of the emergence profile it has, I can send this information to my lab technician. This way, the lab technician is going to be able to replicate or copy this into my abutments or my finishing restorations. And it's a very simple step to do. All we need is an impression coping, composite, GC pattern, or flowable, whatever we want to do. And we just got to copy the contours of our provisional to be able to send this information over. Very important to do is have a good communication with your lab. If you have a good communication with them, you're most likely to have good looking restorations. Now, we've seen a case in which the patient is missing one tooth. Now, we've seen a case in the patient is missing 2 central incisors. But how about that case in which the patient has been missing multiple teeth for a long time? This is what we're going to see right now, and this is the case that we want to discuss today. This is Jenny. Jenny's a 26-year-old female. She presented to her office at Louisiana State University, and she had been with a problem for about 18 years. She had been facing a problem that was not helping her psychologically, not helping her socially, since she's very young in her age. When she came in, I saw her and I said, well, there are some things I can make better in this patient. Yes, I can align the teeth a little bit better, send her to an ortho consult, but I didn't truly realize what was going on in this patient. When she took away her temporary partial, which was her temporary prosthesis, I saw there was a big problem under there. This patient had had trauma when she was very young and had been living for 18 years without their central incisor and her lateral incisor. Huge bone deficiency was then seen in this area. Of course, she's been wearing that temporary partial for this long amount of time. We know that there's going to be some kind of bone defect underlying it. Everything was studied, how much tissue we needed, how much bone we needed. We saw that there was missing soft tissue both in the horizontal aspect as well as the vertical aspect. So we classified this case as a class 3 Siebert classification. Now, we needed to bulk this out. We knew we needed some kind of bone regeneration and some kind of soft tissue regeneration to have a predictable result, especially when we had a bone defect this big. So it was very important for us to communicate to our surgeon and express to them what we wanted to do, how we wanted to treat this patient, how we wanted to approach this case. After a radiological study, we saw that we had a little bit over 4.5 millimeters of bone in this area, and that we needed to bulk this out to make it look a little bit nicer and for us to be able to deliver an implant in the correct position and in the correct of the correct dimensions. So we presented a treatment plan using the digital smile design. If you remember the case we saw just in the beginning when we were talking about form, this is the case of Jenny, and this is how we explained to the patient. Second thing we had to look into is how many implants are we going to place in this case? Are we going to place 2 implants like we did to replace the 2 central incisors, or are we going to place 1 implant? What things do we have to take into considerations when we decide this? Dr. Salama has a very good lecture about this. It's in Dental XP about the dilemmas of 1 versus 2 implants. But among the things that we have to take into consideration is the mesiodistal space that we have from the remaining teeth, the bone level of is present, and of course aesthetic predictability of our restorations. Now, the huge challenge in this case is to deliver that papilla. Are we going to be able to have a good papillary fill? We know from Tarnow in 92 that if we have 5 millimeters from the crest of the bone to the contact point of our crowns, we're going to have a papillary fill for about 100% of the times when it comes to 2 teeth, right? And that this number is going to decrease as this distance from the crest of the bone to the contact point increases. Now, when we have implants that are neighboring tooth, does this behave a little bit different? We know if it's 1 implant neighboring a tooth, then the bone architecture is going to be more dependent on the natural tooth that is still in the patient's mouth rather than the implant. So of course we have to take into consideration and know that the patient must have a healthy bone, still have 5 millimeters of less from the crest of the bone to the contact point of the 2 crowns, and must have an adequate volume of soft tissues. But how about when we have 2 implants? If we have 2 implants, then this becomes more of a challenge. Tarnow in 2003 came up with a study with his collaborators in which they studied 136 sites and found out that the average papillary height between 2 implants was 3.44 millimeters. This had a range from 1 millimeter to 7 millimeters, but this was their average they found. So we have to know that when we treat cases in which we have 2 implants side by side, we're going to run into the problem that we might have a very short papilla. And take this into consideration when we treatment plan. Based on this, we got to understand once again the form that we have to give to this teeth. So, what problems do we face in this type of cases? Is the patient has lost his teeth for a long time, there is going to be a reduced amount of bone, and of course, if we need bone grafting, there is the chance of having a more reduced papilla in these cases. So this is becoming the true periodontic challenge that we have to help, in which we have to try to communicate well with our periodontist or oral surgeon so we can deliver good-looking restorations in cases like this. What criteria do we use to pick 1 or 2 implants? This is another approach with Dr. Frank Spear. First thing we got to know is if the patient is going to lose their teeth, if there is the absence of periodontal disease. Is there periodontal disease in this type of patients? Is the level of the bone, if the tooth are already missing, at the right height for us to put contours of crown, or is the level of the bone at inadequate heights that we're going to need to do some kind of prosthetic alterations to our crowns, like placing pink porcelain, to make them look a little bit more aesthetic. So in the case of Jenny, she did not have this teeth, but the bone was not precisely in the perfect spot, but it was pretty close to be right there. We knew we had to graft, but we thought that we can achieve something that could look good in this patient. If the patient was going to lose her teeth and did not have periodontal disease, we have to consider what tooth are going to be extracted on this patient. Is it going to be the 2 centrals, like the case we saw earlier? Is it going to be a central and a lateral, or lateral and a canine? Based on this, we're going to measure the distance we have to place the 2 implants. If it's going to be 2 centrals, we're most likely going to have enough space to place 2 implants, so we can consider placing 2 of them. Another reason is that if we place 2 implants in the central incisor points, then even though we might have a reduced papilla, since we don't have another thing to compare it with because this is a central papilla, it can be a little bit more forgiving than if we had a central and a lateral in which we have the opposing side which we can compare to. Then this becomes a little bit more of a problem. Another thing to consider when it is a central and a lateral is the fact that we might not have enough mesiodistal space to place 2 implants. So we're going to have to place 1 implant and cantilever the other crown. Same thing happens when we have a lateral and a canine. So these things we really do have to consider at the moment of planning these cases. Timstra came up with another study in which he wanted to see what the patient's judgment was of 1 versus 2 implant when it comes to aesthetics. And he also measured some probing depths, survival of the implants, the papilla, and of course the satisfaction of the patients. And what he found is that there was no significant difference among placing 1 or 2 implants in this type of cases. So let's go and see what we treatment planned for Jenny. First thing we asked Jenny was, Jenny, we need to do some bone grafting. We need to bulk that soft tissue and the bone out to make your crowns look beautiful, make them look a little bit more like teeth. Second thing, we need to distribute spaces a little bit better. So that way we can plan whether we want to place 1 or 2 implants. At that point, Jenny said, Doctor, I don't want to do ortho again, so I'm going to just ask you to restore the site, if you can, like it is. So based on this, it was decided that we were going to place only 1 implant because we did not have space for 2 implants. We definitely did not have space for 2, and even by just placing 1 implant, we were going to have to play a little bit with the shape and the prosthetics to be able to fit 2 crowns in that space. Then we were going to deliver 1 abutment and of course a crown with a cantilever lateral in the central incisor that it was implant supported. First step was bone grafting done by Dr. Michael Block, which was a surgeon in this case, in which it was decided to use xenograft material because we wanted this material to stay in the mouth for a long time, and a resorbable collagen membrane. This was the process. The patient came in, she was put under anesthesia, and the bone grafting was done, and the collagen membrane was used right over our grafting material. We waited for a period of 6 months right after this grafting was done to be able to see how much bulk we have gained and how much space we had for that implant to look natural and look good. This was the ICAT imaging after the 6 months, and we knew at this point that we can go ahead and place a dental implant. Most of the implant was going to be engaging the natural bone and was not really going to be on our xenograft. Dr. Block decided to do implant at this point, and we were going to discuss what type of surgery we're going to do. Did we want to open a flap? Was it going to be guided? Was it going to be just a fully exposed surgery in which we were going to see how much bulk of bone we had or not? First thing we had to do once again was go back to a provisional stage, reset our anatomic landmark so we can plan for this implant. We did a wax up in which we used some denture teeth, and by using this denture teeth we were able to deliver it in the patient's mouth in the form of a Maryland bridge, in which we used some reinforcement mesh in the lingual aspect of these 2 teeth to be able to bond them to the canine on one side and the central incisor on the left side of the patient's mouth. We decided that the surgery was going to be done fully guided because we did not want to interrupt the soft tissues by lifting a flap, and we thought that we could be very predictable with this type of surgery. Surgery date came 6 months later. Patient was anesthetized, and the implant was delivered as planned from your surgical preparation or surgical planning for Jenny's case. But how precise are these surgical guides? Well, in a study by Turbush in 2012, he studied 150 implants in which he used 10 soft tissue supported guides, 10 osseous supported guides, and 10 dental supported guides. To his amaze, of course, there was deviations in all of them, including the dental supported guide, which there was 2.26 degrees of angle deviation, 1 millimeter deviation in the platform, and 1.5 millimeter deviation in the apex, just in a case like the one of Jenny, in which the guide was pretty much supported by teeth all around. Of course, this increased if the guide was supported just by soft tissues. Now, Van Asch in 2010 did a study in which he had a 4.7-degree inclination of implants after placing the surgical guides in, 0.8 millimeter deviation in the platform and 1.8 millimeter deviation in the apex. So we're seeing that there are some errors that can happen and can alter the positioning of our implants even though we have a fully guided plan. This can be done during the design of the guide. We could err during this point, during the placement of the guide, especially if it's not a tooth-supported surgical guide, during the fixation, during the support, and of course, trans-surgical events that can happen. Now, experience also plays a big role in this. Experienced surgeons are most likely to have better results than non-experienced surgeon. In a study by Cushion in 2013, he placed 100 implants. 25 were placed by one dentist that was not experienced, the other 25 by another dentist that was not experienced, and the other 50 were placed by 2 experienced surgeons. He found that the experienced surgeons had less deviations at the apex and less deviation of the platform of the implants, and of course less angle alterations. All of this was done in stereolithographic models. So we can conclude for this that at more experience as a surgeon, you're most likely going to have less problems at the end of delivery of these implants. Once we had the implant done, we came into the conclusion that even though we did not raise a flap, we were going to end up needing some connective tissue because the tissue that we had was a little bit weak, and we wanted to make sure that we had some good keratinized tissue, some good connective tissue under that site. So the connective tissue procedure was done on the patient, and after this, of course, we started thinking about provisionalizing this case a few months later. This is the way she looked. Once this connective tissue was ready and it was already stable, we went ahead and did our provisionals. When we're thinking about provisionals in these cases, we have to think about how we can make the soft tissues look better by the design of our provisionals. We know that the soft tissues around these implants are very weak, and we don't want to be retrieving the provisional many times because we're going to be altering this, and we can run into the possibility of having recessions. Dillon 86 described 1.77 millimeter recessions after the connection between the implant platform and healing abutments or prosthetic devices was made. APSA had pretty much the same numbers, 1.75 millimeters, and many other authors have described recessions happening after that connection between the implant platform and any kind of prosthetic device has been made. So we want to try to leave those provisionals in and do as little modifications as possible before we deliver our final restorations. Another thing that we have to consider is how are we going to design the critical and subcritical contours of these provisionals. That means how are we going to design the space of this provisional that we don't see, the space that is under the gingiva, on the runway space from the platform to the cervical aspect of a restoration. Is it going to be flat? Is it going to be convex? Or is it going to be concave? There's not much literature out there about this, but Su in 2010 has a very good article in which he explains the critical and subcritical contour and the indications for making each one of these kinds of provisionals in these patients. So this was the way that the provisional ended up in Jenny's case. When I placed the provisional, I noticed something, and it was that the implant was truly not in the precise site that we had planned it before we did the surgery. When we did the planning in the computer using our mock-up and using our surgical planning software, we had planned that implant to be a little bit more mesial. Another thing we noticed is that the soft tissues were looking a little bit strange. We had redness in the most cervical aspect of that area, and even though we knew that there was connective tissue under there, we kind of got concerned about that. Now, how were we gonna do to compensate for this positioning of the implant? We had to come up with something, and this is why material selection is very important, because we wanted to drift that the emergence of that crown a little bit more mesial and hopefully be able to deliver that papilla at the end between the central and the lateral. Now, we were facing a problem in this case, and we had to find a way to solve it. So this is why it's very important to have the adequate material selection. What type of abutment were we going to use? Were we going to use a zirconia abutment? Were we going to use an titanium abutment? If we were thinking about using a zirconia abutment, we got to think about what indications we were going to use we use zirconia abutments for? Do we use it only for aesthetics of the soft tissues, aesthetics of the restoration? Does it really have an effect on the health of the soft tissues, or does it not? Many studies have been made in which they had compared zirconia versus titanium to see the amount of insertion or the amount of collagen fibers attaching to this type of materials, and they have not found difference between any of them. It's very rare to have studies among humans. In 2006, the GD, which is one of those few studies, found that there's less number of inflammatory cells around zirconia than titanium, probably because it's a little bit more polished. Other studies like Kohal in 2004 in monkeys found no difference, and Werlander in 2008 found no difference as well. When we use titanium abutments, we have to consider certain things. Of course, when we're going to use titanium abutments, we're going to try to use them in posterior teeth, because it doesn't really matter to the ceramists whether they have 100% the perfect color matching than like they have to have in the anterior sector. Now, if we're going to use titanium abutments in the anterior sector, we're going to try to have gold-coated titanium abutments, because it makes it easier for a lab technician, for us to deliver good-looking restorations because of light transmission. One thing we have to consider is the biotype that the patient has whenever we're going to deliver this type of abutments. If the patient has a thin biotype, it's most likely that we're not going to have a good-looking result if we use titanium abutments. If they have a thick biotype, then it's most likely we're going to be able to do this. In the case of Jenny, we had to use a titanium abutment because we wanted to shift that abutment mesially, and we're going to have somewhat of a cantilever. So we wanted to make sure it was a strong material that was going to hold on. And based on this consideration, then our restoration in the end was going to be of a different material. So that's why our material selection changed. What options did we have? We could do zirconia, we could have done PFMs to hide this color out, and we decided to go with metal ceramic restoration because we knew that a well-managed metal ceramic restoration was going to be good looking, and the connectors were going to be a little bit less wide, and it was going to look better than having thick zirconia connectors in the anterior sector of the mouth and make them not look as nice as this would. Now, we know that PFMs are well used in dentistry. As a matter of fact, in 2003, there were still 65% of all the restorations placed in the mouth. So placing PFM crowns in the anterior sector of the mouth is not something that can't be done. So we've worked through this case. We've planned it, we've placed the implant, we have done soft tissue grafting. At the moment of cementation, we gotta be very careful, and we have to look into certain things. We got to understand that if we have excess cement, we most likely will have peri-implant problems like bleeding, like suppuration, bone loss, or even failure of the implant. So we have to be very careful. There have been many studies. The first one that I'm going to talk about is Wilson in 2009, in which he studied 42 implants, and 34 of them had cement. 20 of them were control implants, and of the 34 that had cement, he found that 81% of them had peri-implant disease. 81% of them had bleeding because of this excess cement. Once the cement was retrieved, then the soft tissues came back to look better than they looked before. Now, Korch in 2013 studied 126 implants. 75 of them had cement. Out of these 75, 60 of them presented bleeding, and 15 of them presented no bleeding. 16 of the 75 implants had also suppuration. So he came up with a number that was 80%, in which he found bleeding associated to them. 80% of these implants that had excess cement around them had associated bleeding. He also found that if it was retrieved, then the soft tissues looked better. So what can we do to make these soft tissues better? What can we do to prevent this excess cement? Here's a little technique in which we're going to copy a die of the intaglio surface of our crowns. We're going to use integrity. We can use any type of material. We can use pretty much GC pattern if we want to. We can use Flutar D. We can use Regisil to make the copy of this intaglio surface. And what we do then is, once we have this copied, what we do is pretty much cement the crown on this jig we've made. So all the excess cement that was going to come out of this crown, instead of coming out in the patient's mouth, comes out in the jig. We can clean it off, and once we've cleaned it off, we have just the right amount of cement to deliver in the patient's mouth. That means all the excess cement has been removed outside of the mouth, and at the moment of delivery we virtually have very little or no excess cement. Dr. Wadwani talks a lot about cementation on implants, inclusive this technique included, and it is very interesting to read his articles in which he talks about radiopacity of cements, excess cements, and the damages, and certain techniques to make this amount of cement less in the patient's mouth. This is how the implant looked at delivery. Like I said, we saw that the papillary field was not the adequate one. Unfortunately, we could not achieve the papillary field as we expected. Now, 4 months down the road, we can see that the soft tissues are starting to change around this restorations, and they're starting to creep into the spaces we designed. Now, is this a success or a failure for a patient that has been without teeth for 18 years? That is to judgment of the clinician and of course judgment of the patient. In this case, Jenny was very satisfied. She was very happy with her result, and this helped her be a little bit more outgoing and helped her communicate a little bit better, and she was very thrilled with the result at the end. This is an overview of Jenny's case from the beginning appointment to the moment of cementation. We ran into some troubles, but we had some alternatives, and our material selection helped us to solve these problems that we ran into during the process. So as an overview, it is very important to understand that planning is the most important thing when we come to see cases with anterior implants. It is also very important that every single surgical step is based on a prosthodontic planning. That means we got to have a good treatment planning approach, whether it is the digital smile design or other. You judge by yourself, but if we have a good treatment plan approach, we're most likely going to deliver good information to our surgeons, and they're going to be able to place the implants where we want them, not where the bone necessarily is. And it also is important to respect the dimensions and distances between teeth and implant and implant, among other things. Implants have changed and they have evolved, like we discussed in the beginning. Now, they have had many leaps, and there has been many paradigm shifts in implant through years. Now, sometimes we want to ask ourselves, when is it that we're going to be able to predictably grow that papilla between two implants? Is this growth of the papilla between two implants, is this predictability going to be the next big paradigm shift in implant dentistry? Is it going to be because of an act of science in which companies are going to develop better surfaces, or clinicians are going to develop better techniques to place these implants, or is it going to be another random act of serendipity? I want to really thank you guys for spending this time with me, and I really hope you enjoyed it. If you have any question, if you have any concern, or have any type of inquiry you want to make, my email is on the profile, and I would be most likely very glad to answer back or be in contact with you guys. Thank you very much. I really appreciate your time and attention.